Good morning, students. As radiographers, we always begin by checking the request form before we do any examination.
Yes, doctor.
The request form guides us on what investigation the patient needs. So looking at this request form in front of us, I want you to tell me the graph examination are we going to carry out? Think carefully, and identify the exact examination requested before we proceed.
Renal tuberculosis? But why chest x-ray?
Is exactly why radiographers must think clinically. Let's think clinically. What causes tuberculosis?
Mycobacterium tuberculosis.
Correct. Which organ is commonly affected first?
Notice the clinical details here. Let's discuss this with the rest of the group.
Is that the exposure index?
Exactly.
The lungs.
Good. So tell me, how does renal tuberculosis occur?
Spread from the lungs?
Exactly. Tuberculosis commonly begins in the lungs after inhalation. From there, the lungs may still contain active disease. So even when the patient presents with renal symptoms, the lungs may still contain active disease.
So chest radiography is performed to assess pulmonary involvement?
Excellent. That is clinical reasoning.
In real clinical practice, radiographers must never focus only on the organ written on the request form. What abnormalities can appear in pulmonary tuberculosis?
Upper lobe infiltrates.
Cavitary lesions?
Fibrosis.
Good. We may also observe consolidation, pleural effusion, nodular opacities.
So chest x-ray helps evaluate disease activity?
Yes. Enough theory. Let's move into the diagnostic room. For every examination, patient preparation matters. Please remove necklaces.
Please remove necklaces, metallic objects, and clothing artifacts.
To avoid image artifacts. Correct.
Always. Confirm identity, explain.
We're going to take an x-ray. I'll explain the procedure.
Okay, is it safe?
Yes. We are performing PA chest projection.
Why PA instead of AP?
Excellent question. PA projection minimizes heart magnification because the heart lies closer to the image receptor.
Patient positioning is confirmed before exposure. The chin is elevated to prevent superimposition over the upper lung fields. The shoulders are rotated forward to move the scapulae laterally away from the lung apices. The hands are placed on the hips to further rotate the shoulders forward and improve lung field visibility. The anterior chest wall is placed in direct contact with the detector to reduce magnification and improve image sharpness. The central ray is directed at the level of T7, which corresponds approximately to the level of the inferior angle of the scapula in a standard PA chest radiograph. A full inspiration is essential in chest radiography. This means the patient should take a deep breath and hold it before exposure. The reason for full inspiration is to maximize lung expansion. When the lungs are fully expanded, more lung tissue is visible, and the diaphragm is pushed downward, allowing better visualization of the lower lung zones. If inspiration is inadequate, the lungs appear underinflated. This can artificially increase lung density and may mimic pathological conditions such as basal lung collapse, lower zone consolidation, cardiomegaly exaggeration due to crowding of structures. Therefore, poor inspiration can lead to misdiagnosis if not properly assessed. Exposure factors such as KVP, MS, and time of exposure are also critical. Correct exposure ensures adequate penetration of the thorax, proper visualization of both lung fields and mediastinal structures, balanced contrast between air-filled lungs and soft tissues. Incorrect exposure may lead to underexposure, where lung markings appear too white and obscure pathology, overexposure, where lung details are lost due to excessive blackening, increased radiation dose due to repeated imaging, diagnostic errors due to poor image quality. This image represents a normal posterior-anterior PA chest radiograph. A systematic approach is used to evaluate the image. First, assess lung fields. The lung fields are clear, meaning there are no abnormal opacities such as consolidation, masses, or infiltrates. The lung markings are visible and evenly distributed. Next, evaluate the costophrenic angles. These angles are sharp and well-defined. This indicates there is no pleural effusion or fluid accumulation in the pleural space. Then assess patient rotation. The medial ends of the clavicles are equidistant from the spinous processes, indicating no rotation. This is important because rotation can distort mediastinal structures and simulate pathology. Inspiration is adequate. A sufficient number of posterior ribs are visible above the diaphragm, confirming proper inspiratory effort. The cardiac silhouette is normal in size and shape. The cardiothoracic ratio is within normal limits, meaning the heart is not enlarged. Finally, exposure is optimal. The image has appropriate contrast and density, allowing clear visualization of both soft tissue and lung structures. A normal chest radiograph is essential as a baseline for comparison when evaluating pathological conditions. This radiograph demonstrates abnormal findings consistent with pulmonary tuberculosis. A systematic evaluation reveals several key abnormalities. There is increased radiopacity, particularly in the upper lung zones. Increased radiopacity means that the affected area appears wider than normal lung tissue due to infection or consolidation. Upper lobe infiltrates are present. This is a characteristic feature of pulmonary tuberculosis because Mycobacterium tuberculosis has a higher oxygen requirement and therefore preferentially affects the upper lobes where oxygen tension is higher. Fibrotic changes are also visible. Fibrosis indicates chronic infection, where lung tissue has been replaced by scar tissue due to prolonged inflammatory response. There may also be cavitation present. Cavitation refers to the formation of air-filled spaces within areas of lung consolidation due to tissue necrosis. This is a classic radiographic feature of advanced tuberculosis. These findings together strongly suggest active or post-primary pulmonary tuberculosis. This explains why a chest radiograph is an important investigation, even when the primary clinical suspicion may be related to another organ system such as the kidneys. Tuberculosis is a systemic disease and can affect multiple organs simultaneously. To summarize this session, chest radiography is performed in cases of renal tuberculosis to assess possible pulmonary involvement, since tuberculosis is a systemic infectious disease. There is a strong relationship between pulmonary and extrapulmonary tuberculosis. Infection in the lungs may coexist with or spread to other organs, including the kidneys. Proper PA chest positioning is essential for diagnostic accuracy. This includes correct alignment, scapular displacement, full inspiration, and proper centering at T7. Radiation protection principles must always be applied to minimize patient dose while maintaining diagnostic image quality. Image evaluation involves systematic assessment of lung fields, mediastinum, bones, soft tissues, and exposure quality. Finally, tuberculosis has characteristic radiographic features such as upper lobe infiltrates, cavitation, fibrosis, and increased radiopacity. Before concluding this session, consider the following clinical questions. Why is chest radiography requested in patients diagnosed with renal tuberculosis? This question tests understanding of tuberculosis as a systemic disease and its potential pulmonary involvement. Why is PA chest projection preferred over AP projection? This relates to image accuracy, reduced cardiac magnification, and improved diagnostic quality. Finally, mention 2 radiographic findings seen in pulmonary tuberculosis. This reinforces recognition of classic features such as upper lobe infiltrates, cavitation, fibrosis, or increased radiopacity. Consistent practice in chest radiograph interpretation improves diagnostic confidence and clinical accuracy in radiography.